going to rotate around access to sanitation. We've got people presenting on different aspects around sanitation. And the first presenter is going to be Hari, who will be talking about informal, invisible, and illegal work, a case study of manual and mechanized pit emptiers in a small town in India. And we'll have a second presenter who would be Prince, who will be talking about how risky is the work of sanitation workers, a quantitative and qualitative assessment of health and safety risks among latrine operators and emptiers in Kumasi Metropolis, Ghana. So time is one thing I usually treasure, so I'd love to start straight away, and then we have Hari present to us. Hari, the floor is yours.
Yes. This is moving well. Okay. Good evening, everyone. Myself, Hariprasad. I'm a PhD student at IIT Bombay, and I present my work on informal, invisible, and illegal sanitation work, a case study of mechanized and manual pit emptiers in Alleppey town of Kerala. So this is more of a qualitative case research, and it does not mean that the entire state or the entire country has a similar condition, but many of the towns in India have similar condition, and I'll get into the nuances of it. So I'm working as a part of the Towards Brown Gold project, funded by IDS Sussex, funded by UKRI GCRF, and led by IDS Sussex and Ethiopia, Nepal, Ghana, and India. We are looking at sustainable sanitation in rapidly urbanizing areas in Asia and Africa, basically the small towns. And my study, and the focus is on reimagining shit or the fecal matter as brown gold or circular economy idea. But it's a long way to go, and we are currently looking at the dynamics of FSM in these small towns. My study delves into the contemporary dynamics of FSM, with a specific focus on the distinct challenges faced by manual and mechanized pit emptiers. So we know that there is a significant change happened in the sanitation sector in the past few decades, and still 1.7 billion lack of sanitation services. But the major focus in Global South is on the first generation issues of containment and storage, the use of toilets in off-grid solutions, in off-grid sanitation system. We don't have conveyance and transportation and treatment and reuse of any other kind of activities other than after the septic tank, most of our work stops. But recently there is a change happening, but the case study I'm presenting does not have that change because of multiple reasons, and I get into the nuances of it. The shift is triggered by the technology and the legislation, the laws and policies to eradicate the manual scavenging. And it also changed the way the workers have been working and the group of workers. So there is a scarce literature other than looking at the health hazards of workers. I'm looking at the social, economical, and cultural aspects. Why this study? More than half of urban households in India, we know that it's on-site sanitation system, and we have off-grid, we don't have underground drainage. And there is no credible data on desludging, treatment, or safe disposal. And we know that sewer lines are costly, and in densely populated cities and towns of India, it's not possible to construct an underground drainage, and we can't afford also. There is a lack of roadmap. There was manual scavengers who used to clean dry latrines, and still the sewers and the drainages are cleared manually, and there is no roadmap for the rehabilitation of these people because still we lack technology in different aspects. The major challenge is that when the toilet technology changed from dry latrines to flush toilet, the FSM, the state government and the central government took hands off, because the septic tank challenge does not pose a direct challenge on you, unlike the dry latrine, which has fecal matter on the roadside or on the households every day. So the small towns, I specifically look at the small town of Alleppey, because small towns are mostly at the bottom of the urban hierarchy. We study megacities, metropolitan cities, then cities, towns, and small towns come the later stage. So I think small towns are largely underrepresented in the research. And the main thing is the link between SDG 6.2, safe access to sanitation, and SDG 8.8, economic growth and the decent work and labor dignity. 8.8 discusses on labor rights, dignity, and the safe working environments. So I adopt a qualitative research approach using key informant interviews, FGDs, non-participant observations. So the actors include manual and mechanized pit emptiers, government officials, elected representatives, and the local residents. So I employ thematic content analysis to come out with my results. This is the study area. I'm looking at Alapi town of Kerala. It's a southern part of India, Kerala state locates. And Alapi is a small town with a population of 177,000, and it is called Venice of the East. It is mostly a marshy kind of area, and it is also a tourist spot, and it's a hotspot of floods and different other problems because of the ecological vulnerability. It's ecologically fragile because one side is sea, other side is backwaters, and the depth to water table is 0 to 2 meters. So you can't have a good on-site sanitation system because you can't dig deeper with the septic tank. And 65% of the household have septic tanks and 32% have pits. But still the septic tank needs the cleaning because the proper usage of septic tank does not happen. Also, Kerala and town of Alapi is known for labor struggles. So that is another reason why I'm looking at the laborers, the sanitation laborers. So we are stuck after the conveyance stage in this picture. We don't know what is happening after that. It's mostly an invisible thing. So who and what needs to be prioritized now? I suggest through my research that the laborers should be at the center of the sanitation system, who bridges the gap between sanitation systems and sanitation technology. In the absence of sanitation technology, sanitation laborers are becoming the technology there because we can't afford the technology. So sanitation laborers are important for next couple of years or decades maybe until the sanitation systems are in place. So I'll tell about my work and exactly the empirical details. I'll get into the empirical details. So the mechanized pit emptiers. So mechanized means they're basically using a pipe, a 2 horsepower motor, and a lorry, which is having a storage place. So these are the first picture is the house of the service provider. He does not go for the work. He employs these workers, and he owns a big house, 4 vehicles, he has cars, but these people are paid very low prices. And they go at night for the work, and they do desludging. This is the 3-chambered septic tank, but still it needs cleaning, and they close one by one. And this is a picture of a ring-type septic tank, which is like a bore well. So this is the picture, and I went with them for non-participant observation at night after having a round of 2-3 round of discussion with them. They did not allow me to be with them because of the illegality and invisibility they do in their work. So I'll come to that. This is the manual pit emptiers. They came to Alapi town in 1990s. They are interstate migrants from the neighboring state of Tamil Nadu, and they are coming from Dalit communities, which is the lower caste people in India. And this is their cycle. They stay in the outskirts of the city. They go every day to the town and look for the work. And these are the people who is living in their community. And he was working since 1990. He's around 60 years old. I'll explain. So in my work, I try to look at what is the difference in the nature of work. So the manual pit emptiers, after clearing the top portions of the septic tank, they get into it when it is still the knee, and they clears the waste, clears to a neighboring pit. But at the same time, the vacuum suckers, the mechanized emptiers, they use suction pipes and they dump it in the open or in the water bodies. So that makes their work illegal because that's a public health concern. But at the same time, there is no government or private treatment plans. So at the same time, government knows that the state is responsible, but the government does not have an option to have a treatment plan because of the public protest, not in my backyard protest and other issues. Kerala is actually developed in many of the fronts, but the sanitation issue became a felt problem, felt issue after the 2018 floods. So the disaster made them understand that sanitation is a major problem. And the social background of these workers, the first one, the manual workers are interstate migrants from Dalit communities, and the second is mostly Dalits and other backward classes from the town of Alleppey and neighboring areas. The first one uses bare hands. Sorry, some message said child abduction. I don't know what is this. So the second mechanized pit emptiers uses long pipes, 2 HP motor and a storage tank mounted on a mini lorry. So the wages range from 24 to 30 US dollars for manual pit emptiers, and for mechanized it ranges from 48 to 72 USD. The manual pit emptiers work in the daytime, but earlier they used to work at the night because there is problems associated with the work, because it's called as a dirty work. So still people have stigma associated with sanitation work, and so they used to earlier work at night, but the police used to catch them by saying that you're a thief, you have to show your ID card. So they started working in the daytime, but their work was not illegal because of they do not dump the waste anywhere. They just move it to the next pit. But there is an illegality associated with their work because the manual handling of fecal matter was abolished by the law. And the government, so when you look at the state intervention, state does not recognize that there is such a community lives. And they are anyway migrants, so the government public distribution system is not reaching them. And the work timing of the mechanized workers at night after 11 p.m. because they are dumping it in the open or somewhere, but if the local people sees they are dumping, the police will come, catch them, fine them, and also sometimes arrest them. The societal interaction, there is ethnicity is different for the manual pit emptiers because they came from another state. They does not have a problem regularly, but at some times the people does not give job to them, rather they give it to the mechanized sanitation pit emptiers. So the informality, in the first case, they are self-employment. So since 1973, when Keith Hart defined the term informality, since then informality's definition changed. And in sanitation work, we can see that informal to formal, it's a spectrum rather than we say this is formal, this is informal. So the informality associated with the manual pit emptiers is self-employment, and the mechanized pit emptiers are actually can be called as an entrepreneur, but their work is precarious, and the only the profit is for the owner of the lorries, the service provider. And they actually advertise this thing in the newspaper, and the manual pit emptiers have to, they get the job only through word of mouth. Why the illegality aspect comes in manual pit emptiers? As I said, manual handling of fecal waste is abolished by law 2013 as well as in 1993. 1993 law was not very effective. They came up with 2013 law as well as the rehabilitation, which is not happening actually. And the illegality associated with the mechanized pit emptiers is dumping the septage waste in the open areas or water bodies, causing problems. So invisibility is they're socially invisible, and the mechanized pit emptiers are physically also invisible as they work at night. So I conclude by saying a couple of points. So both groups are informal, as I mentioned, self-employment and entrepreneurial. So informality is a site for critical analysis in my work. So the informality triggers illegality as well as invisibility, and the regulative limits of the state in providing the basic service of sanitation comes out to be a major reason. And the waste-related work. So the workers either get into solid waste management, and if this stops or they are not finding any job, they go to another work related to waste. So they are in a vicious cycle. The lower caste, low income, ethnic minorities are working in the waste related work, and they are in the vicious cycle of waste work. So the agency of workers are instrumental in overcoming this. So agency and marginality are the major points I discuss. And two set of workers, the mechanized and manual, are interdependent, because if one says that we can't clean this because of the manual pit emptiers cannot go deep into the septic tank, they say that you please call the mechanized pit emptiers. At the same time, mechanized pit emptiers cannot go deep and clean manually, so they say that you call the manual pit emptiers. And in most of the urban areas where there is no place to remove the fecal matter to another pit, they call the mechanized pit emptiers, because the mechanized pit emptiers take it and dump it somewhere else rather than their neighboring areas. And there is an absence of rehabilitation, and the treatment plans is not there because of the NIMBY issue. And thank you. This is the people sitting on the opposite side are the mechanized pit emptiers, and the municipality wanted to have a treatment plant, but they cannot afford to buy the lorries and other accessories. They call these people, this will happen in a PPP model, and these people now have the agency. They are invisible, they were working at night, but they wanted to be there with them because their families and children are seeing them as doing some bad work at night. So they wanted to be with the system in somehow. So this is the first meeting happened, and there is a hope for change. Thank you.
All right. Thank you so much for a great presentation. I think in the interest of time, we'll have only one question, and then we'll move on to the next presenter. Yes, sure.
Thank you. I'm Maya Ramaswamy. I'm with CDC. Thank you for this presentation and for highlighting the many factors that make this population very vulnerable. I'm wondering, you mentioned the kind of historical labor struggles in Alleppey, and Kerala has a long history of unionization. So I was curious, did you think about capturing the perspective of any union leaders who maybe are not in this particular field, but are working in related areas? And also, have you seen whether there's a kind of movement, even though it's illegal, to kind of organize around this work?
Yeah. There is no movement, and nobody recognize and go into the depth of these workers, but there are workers. So my work, larger work, is fecal waste management workers, solid waste management worker, and municipal sweepers. So the municipal sweepers are under the municipality. They have an association, labor union, left party, trade unions, but they also facing some issues, but they have not having a precarious job. Theirs is a permanent job. So the government is only looking at the sweeping job. The remaining solid waste management is a semi-formal job by self-help groups and women self-help groups, and the fecal waste management is completely informal. So the labor struggles and other factors were in the 1950s and 60s. So I had a poster yesterday regarding the context of the study, that was the evolution of sanitation work and workers over the time in Alleppey. So the labor struggle was there when the manual scavenging happened, and they got a lot of freedom, like they were there was untouchability at that time, and they were not allowed to get inside the municipal hall. So when the communist government at the local municipal level came in, they allowed all the workers to get inside the municipal hall by wearing footwear. So earlier they were stopped from wearing footwears. So there was a change, but when the toilet technology came into flush toilets, and the flush toilets connected to a septic tank, the issue is not very pertinent or very, you can't see the problem every day. So one household have a filled septic tank, they will manage it somehow by calling these people, and second have another day. So it's not a uniform every day. So there is no pressure until the flood happened in Kerala. So yeah. Thank you.
All right. In the interest of time, we'll move on to the next presenter, please, who would use 12 minutes presenting and then 3 minutes discussion. Yes. Please try to stick to time. Yes.
Okay, good afternoon to everybody. So I'm Prince Antwi-Agyei, and I'm a senior lecturer at the University of Energy and Natural Resources in Sunyani, Ghana. So this work is part of the bigger work being supported or funded by WaterAid, WHO, ILO, and other partners. So I'll be presenting parts of the findings from a study that we've titled How Risky is the Work of Pit Emptiers and also Public Toilet Operators. So I will focus more on the quantitative findings, but I will show a video documentary that will depict some of the qualitative findings. Then I'll also give a summary and some other recommendations. So what necessitated this study? So globally, all of us, or governments, especially in low and middle income countries, are striving to provide safely managed toilet facilities for households. It's difficult, and because not every household will be able to have access, they are complemented by shared sanitation facilities, and in this case, public toilets. So because we have public toilets, it means it should also be operated by janitors and attendants. In developing countries also, sewage or sewer network is something really difficult. So in the case of Ghana, we have less than 10% of certain cities connected by sewer network. So predominantly, the type of facilities that we use are on-site, and because they are on-site, they will become full by and large. And when they become full, how are they also emptied? Then that also brings in the work of either mechanical emptiers or manual pit emptiers. We are all aware of the challenges of the occupational health and safety issues that they face, but scientifically we have limited evidence in literature, and that's what this study sought to do, to be able to identify the specific, job-specific hazards associated with the various categories of sanitation workers along the sanitation chain, then to also quantify these risks. Okay, so we use various approaches. Overall, we were able to interview over 200 of these various sanitation workers. We had key informant and focus group discussion with regulators, employers, association leaders of these workers. Then we also had a stakeholder dissemination workshop, so where we disseminated the findings for them to also validate, and also had a co-creation exercise where they themselves brought forth interventions that or strategies that they think will be able to help them overcome the challenges and also improve their well-being. So with the data collection, basically descriptive, but then with the quantitative part focusing on the risk scores, an aggregate of the frequency of that hazard occurring, so the likelihood or probability, then also the severity of these hazards. So we put them together on a scale, each of them a scale of 1:5, putting it together up to 125, we rank them from low to extreme high. Okay, so I will show a video documentary to let you understand some of the problems that
Kumasi is Ghana's fastest growing city. Today, about 3.4 million people live in Kumasi, and all these people need sanitation service, whether at home or at work. But who are those providing sanitation services for all these people? And what risks are they exposed to?
Yes, third driver. Car. But normally, a Juma radio, Yana, a boy attacker. I coffee with Bano. On a quantum of a council who was actually, I don't, I better open two for the buffo. Remember, so dear, young woman, there's some food over city. So now for crowd, very conventional. Not your crowd of it, catch down. Hey, now, Brown, where dear, two do Sunday did. So the one who saw those serious man, or two said, I didn't because you at the other time. I've done already. What do I did you? We don't want to do everything you did.
Hospital bi or a friend said, Panny, you know, two see one, a war, so massa. Human day, probably a womb and a breast womb, a brepa easy. Go to Cocrana, we see from Lucana washing. My Jama will not talk about that. We see no washing. Mura, a year friend saying, I'm going to be. No, I'm an animal. I know what I bought. Tears were a woman market. That time, be any fear of it. I am an A.
People think say be like a young thing have your way. Last because people need their time say like toilet human being. So wow, mommy may. And I'm like Mitchell said, a Jimmy day Juma. If you said my one ASN cornable. I'm released me back see. Like I'm the literature and it is a scarecrow and home to me.
Sometimes once anybody or war bar, I send a piffin, when they will have been.
Okay, so thank you. This is a 20-minute video documentary, so this is just a shorter version. So I present snippets of the findings. So it's predominantly by male, then most of them are also with the youth. And in terms of education, about a third had no education, the others primary to junior high. In terms of the income that they receive, so the vacuum truck operators, they receive the highest. About $300 per month. Then the minimum are from the public toilet operators, less than $50 a month. In terms of the common diseases, headaches, waist pains, body aches, they are the top 3 diseases associated with these workers. Then in terms of health and safety mechanisms, Most of them reported to use PPEs. Most of them don't have any contract. They are unaware of the labor law or the workman's compensation, which somehow guides them in their operations. Then about 20% of them, because of the nature of their work, resort to some lifestyle behaviors, either drinking of alcohol, smoking, or a combination. With the top 5 hazards, I wouldn't be able to go through all this because of the time, but I will just give a summary. So for toilet attendants, the key risk was back pain, and that one is as a result of the prolonged sitting. Genitals was stigmatization and verbal abuse. Mobile toilets operators were infection from inhalation of foul odors, then truck drivers, infection from contacts to feces. Then with this one, I will skip because the video documentary highlighted most of them. Then what were the key recommendations from the stakeholders during the co-creation workshop? So they proposed that we register our sanitation workers to give them some kind of identity, provision of a safe working environment by the employers, improve public education to somehow reduce the stigmatization and the depression that they go through. Then the local authorities should also develop bylaws and institute monitoring regime to help with the enforcement. Then periodic stakeholder meetings, because my time is up. So thank you very much.
Thank you so much for that presentation. I think in the interest of time, we'll have about one question from the audience. Sure. Yeah, I feel like you had a question.
I was wondering, with your methodology, you was doing lots of surveys and focus group discussions. Did you do any structured observations? Because obviously we saw you in the video with the emptiers, and I think the reporting of wearing PPE seemed quite high in your surveys compared to what we saw in the field, and perhaps can you comment on your methodology?
Okay, so we did an observation. It wasn't structured. And as I said, this one was reported. With observation, fine. With the manual, with the vacuum truck operators, it was obvious that they were not using it. But most of these workers were dominated by the public toilet and janitors. And for them, some of them were using the hand gloves and also the Wellington boots, yes.
Any other question? All right. So the third presenter we are going to have is going to be Amin, who would be presenting some of the interesting work about hospital sanitation system and modeling fecal pathogen flow from health risks from urban hospitals in Bangladesh. Thank you, Noor.
You can keep it here. Thank you, Musa. Thank you, everyone, for being here. This is a larger title you were able to see, but due to the lack of time, I'm just presenting the toilet that we have inspected, like more than 2,500 toilets in the healthcare facilities, particularly in the large hospitals. So I will just present that information, but happy to talk about this in the future as well. So as you know that SDG 6 and SDG 3 healthcare facilities needs to be actually safe wash and sanitation practice. So that's why water sanitation, like health hygiene and also waste management, is one of the biggest problem in low-income settings in healthcare facilities. Particularly these three is very crucial because these three has interlinkage among each other, so that if we can actually save this water, like sanitation and waste management, then it will be a very productive things that prevent infection control and prevention within the healthcare facilities. So when we say the healthcare facilities things, you can see that there are a couple of factors actually presented in different type of studies that particularly the toilet to users ratio is one of the biggest factor that we cannot maintain the cleanliness and the functionality of the toilets. So in Dhaka and rural areas, the toilet to users ratio really high that it's very difficult to actually manage. There is a huge queue like urban, like a public toilets. Another important thing is toilet cleanliness and the functionality. So often we found that functionality and the cleanliness is like compromised in this type of settings. And these toilets can be an infection like spreader is most of the cases. Also, as I mentioned earlier about the toilet to users ratio, the optimal toilet to users ratio according to WashFit is 1:20, but this standard is hardly managed. From our previous study in Dhaka city during the pandemic, we have found that toilet to users ratio is more than 100, sometimes more than 50, more than 200 sometimes. So we had the limitation of that study since we conducted the study during the pandemic. So the toilet to users ratio we cannot actually estimate because there was a restriction to go inside the different wards and different type of areas. So these are the research question or the study objective to understand and assess the toilet functionality. Number one, we actually assess the availability of the toilet based on the based on the population proportion or the users ratio, and then we assessed what is the cleanliness and the like functionality or cleanliness of this toilet and how it is impacting, like what factors actually impacting this mega hospital. So why we are doing this like study? Because there are lots of studies in healthcare facilities and also school related to this, but no study has been conducted in large hospital because these hospitals are selected like 500 beds hospital or more than that. So these are the study areas where we have selected about 13 hospitals. So 10 hospitals from government and 3 hospitals for the private hospital. And government hospitals are the like, there are different type of government hospital we have selected, like general hospital, medical college and hospital, and also specialized hospital. For the private hospitals, we have selected hospitals. Those are actually like medical college and hospitals included. And these are the geographically distributed. One, we did not actually get consent from one hospital, so we did not get get access to that hospital. So these are the ethical process we have to go through. So first of all, we went to the DGHS because this was a little bit sensitive that we publish this type of work because the quality we know that is not very much up to the mark. So that's why we have to go through a rigorous IRB process, and also we get IRB clearance from International Center for Diarrheal Disease, also the University of Technology Sydney, and also the Ministry of Health and Family Welfare. So we also get the consent from all the participants that we have actually go through. And for the data collection, what we have done, so first of all, we calculated the number of toilet available in different blocks. So we are try to understand, for example, if there is any medicine ward, how many toilet users in that medicine ward. And when I say users, it comprises of patients, then the caregivers, doctors, nurse, and other supporting staff of the hospital. So we have also focused on what type of toilet functionality. Like we take all the photos of door, then any leakage, then broken pan or broken commodes, or any type of toilets are used for different purposes, for example, storeroom or other things. Then we actually watch the cleanliness. So we also structured observation of all the toilets, like almost like more than 2,500 toilets by in person, and try to see the we have like made some ladder, like not dirty at all, little dirty, very dirty, and not dirty, not usable at all. So this has been actually uptake by this one of this study from Kampala municipality. So there is actually no that much cleanliness ladder in the JMP and other place that can be actually introduced. So this is what we are actually trying to do this. And you can see the toilet users, as I mentioned earlier, the toilet users mean number of people use in different type of toilets from inside and outside of the hospital. So what happened in Bangladesh that for each patient, there are 3 to 5 users actually, like caregivers actually come and they stay in the hospital, and similar things happening in indoor and also the outdoor. So there are a huge crowd actually. At the same time, we see the sanitation mapping. When I say the sanitation mapping, how the wastewater actually flow from hospital to the different community and how that is actually contributing. So the next part actually the modeling, that how the fecal pathogen actually exposing the community, but I'm not going to present this. So this is only to understand what type of wastewater treatment plant in that hospital and how they are functioning. We also did this type of approach to actually collect our data. So we went to the hospital and we tried to talk with the different ladder of the hospital healthcare facility workers and try to get that information. Now come to the results. So these are the 2,618 toilets were observed, and we are very successful observing 85% of the toilets in these hospitals. As you can see, number of hospitals vary from about 500. Then number of toilets actually you can see in the bar, in this bar showing in different type of hospital. P1 and P2 is private hospital, and hospital is H is providing the government hospital. So this is how it is the toilet staff ratio. You can see this one. So why this study? So I'm not able to look here, so it's not changing. So I'm a little bit here. So you can see the toilet to users ratio. So this is the number of overall toilet to users ratio. So blue is the number of toilet, and this red one is the number of users. So you can say here, toilet to staff, overall toilet to users ratio is 28 to, when we calculate the things overall, it seems like it's very, very reasonable. But if you see, it has segregated analysis of the toilet to users ratio. So for the patients, you can see this is like 300, about 300 toilet user, 250 is 164. So when we go further analysis with the toilet to users, particularly in outdoor patients, the toilet to users sometimes is more than 300. In one toilet, we find 900 users, and that could be one of the biggest reason that it's not well managed. So this is the functionality. The toilets found only 60%, 70% of the toilet we found the functional, and it is actually consistent throughout the hospitals. And 65% toilets were unclean. Unclean mean you can see that we have tested, there is some guideline in different manuscript in the community level. They have defined the cleanliness and uncleanliness. We use that data, and you can see the most of the toilets, most of the hospital toilets were unclean, and on an average is 65%. And this is the ladder of that presenting that ladder that very not usable to very clean. So it's also on average it's 61% that made the little dirty or not dirty at all, these two things. And this is the correlation mechanism, that what are the contributors of this toilet cleanliness and functionality. And we found that private hospital is a little bit cleaner, more cleaner compared to government hospitals. And staff toilet were more cleaner compared to mixed user or patient toilet. And at the same time, the building, those were built before 2000, were more old buildings toilet were more non-functional and non-clean compared to the new building. So these are some recommendations that there is a toilet to users ratio number 1. Then patient toilet needs to be actually more concentrated. So there is some other things, you can see that there is no hospital had toilets with MHM facilities, very less number of, and this is the how the wastewater is discharging from hospital to the community. For example, you can say only these all you can see where there is all these 4 or 6 hospitals actually discharging somehow through the ABR or septic tank. But the red one highlighted here is all of the fecal sludge is directly going to the environment. So this is one of the biggest environmental threat because hospital usually discharging pathogens and AMR injections and everything. So this is a very concerning thing here. So these are the team we have actually collected the data. So this is a very short presentation, but we have collected the behavioral aspect. We have also collected the information related to the engineers and also the PWD engineers, users understanding about the functionality and cleanliness. Happy to take any question from here.
Thank you so much, No, for that great presentation. We'll have a question, if you have any question for No. Yes, please.
This slide is not changing, so it's difficult.
Thank you for the presentation. I'm Rajiv from SND. I have 2 questions. One is regarding how did you count the potential user when you are saying toilet to user ratio? And the other one is like, I mean, did you find any difference between the public and the private hospital? And in terms of cubicles, as per the Bangladesh, let's say, the toilet standards, there should be sex segregated, then there should be inclusive cubicles as well. Did you do those?
Yeah. We have done all of that sex segregated and everything because I just this is very quickly I prepared this for this presentation, but I have very detailed presentation. So for your first question, that how I like prepared this toilet users ratio. So actually, what we have done, every toilet is like hospital are the multi-story, like 10 floor or more. So what we didn't actually go through the floor by floor. We go with the toilet block as a unit. So for example, if there is a one toilet block in the medicine ward, we consider as a toilet block for medicine. We counted the number of patients admitted during that during data collection on that medicine ward. And at the same time, we asked the nurse and the caregivers, nurse and other healthcare professional, what is the average number of caregivers come to your, on this particular ward. And they have put whether 3 or 4, that's an average number. And we put with that everything. So we actually collect, like separate each floor at 5 to 6 blocks so that we can understand that what is the exact number of patients in that particular block and what is the exact number of toilet user in that particular block. Because they usually, if you consider whole floor, we will not able to match the number, actual number. Because in different hospital has different type of building structure. For example, in specialized hospital, those are very well organized, but general hospital, medicine ward could be in different places rather than in one place. So we actually make one block. And for gender segregated things, we did the analysis and we found that female toilet were more cleaner compared to male toilet, but mixed user toilet were least clean and least functional. Mixed user toilet mean those toilet used by both male and female. And interestingly, in our study, we don't find any sign for male and female in any hospitals. Those are only reported by the nurse that this is the male block, this is the female block. Hope you get the answer. Yeah, thank you.
Thank you so much. This was really, really great. And I also really appreciated the pictures because seeing just the pictures of the queues was really interesting. So it made me wonder about how long people were waiting, and just the toilet to user ratio is interesting. And I'm also curious how much they're used. But anyway, my real question is, you did a great job showing cleanliness and functionality. Have you done analysis to look at the proportion that are both functional and clean together? Because if you combine them, it might actually get to a better understanding of what is really usable.
We didn't actually do that analysis, but we assume that the ratio will be more when we'll do, because this is an overall crude analysis we have done. But we have the plan to actually do only for the functional toilet and what are the cleanliness ratio, and I will get your point. And this comment has been made by a lot of people, and we are working on this. Yeah, this is a very good question. Yeah, thank you.
All right, let's have our last presenter, and that's going to be Kerry Baker from the University of Royal College of Public Health. She'll be talking about behavior and environmental factors associated with self-reported diarrhea and enteric pathogens in infants discovered by land class under cluster analysis of household living conditions. So the floor is all yours. Yes.
All right. Yeah, so I'll just warn you all that these are a little bit unpolished because I prepared them about 5 minutes ago. And so I'm going to try to fill in the gaps and things that I did not put in words, just to make sure that you're following along with me here for things I didn't put on slides. All right, so the data I'm showing is coming from a study called the Safe Start trial. It was a cluster randomized controlled trial that was conducted in Kisumu, Kenya, in partnership with London School of Hygiene and Tropical Medicine, the African Population and Health Research Center, Great Lakes University of Kisumu, and University of Iowa. I'm not actually going to talk about the intervention. I'm going to talk about an analytical approach to try to understand what's going on in the background of the intervention and why kids enrolled in the intervention, as well as control groups, still wound up having high levels of infection and health outcomes. Background is, of course, you all know diarrhea is still a major cause of morbidity and mortality in children under 5, especially in low and middle income countries. Symptomatic and asymptomatic enteric infections are very common. We focused on food because it was an important transmission route, but obviously there are many other transmission routes that we discuss a lot at this conference. So the intervention targeted food hygiene practices under the premise that this would knock down, would remove foodborne transmission, especially around this point where children are transitioning from breast milk to supplemental foods. Kisumu is in Kisumu County. It has a high under 5 mortality rate, around 79 children under 5 per 1,000 in the population. Also a high infant mortality rate, and the vaccination rate is not ideal. All right, so I'm going to show some data from our timeline in the study, and I know that this is hard. Oh, I'm sorry, I completely did not realize.
You can use the remote.
Oh, okay, let me try sharing again. Just
use the remote.
Okay. Well, good. Now I don't have to worry about you seeing small print. All right. So we enrolled children into the study at 5 months of age, sort of hoping that they were still really being exclusively breastfed or at least receiving some breast milk. When we enrolled them into the study, we did a survey on their living conditions, and we collected a sample of their feces to test via a diagnostic assay called a TACMAN array card. Ours was looking for 19 different types of enteric bacteria, viruses, and protozoan parasites. We then randomized the children to groups, followed up at 8 months of age to do a process evaluation to see whether the behavior change intervention was affecting behaviors. This involved observing children with their caregivers in the home while the caregivers were preparing food, feeding them, and storing it. We collected, so most of the data there was behavioral, and then at 9 months of age, when children matriculated out of the study, we repeated a survey, collected stool samples again, and tested that stool for enteric pathogens as well. Okay, so let me see if I can catch you up. That's just where Kisumu is. It's in Western Kenya. All right, so getting to the point of this, so we came to this analysis because we'd already tried a couple of different analytic approaches for understanding how the different sort of poor hygiene conditions that children were living in were interacting with each other, interfering with the benefits of each other. So for example, if you have a private toilet on site, but you don't wash your hands, does that derail or disrupt the benefits that come from private sanitation? And we tackled it previously using an approach called effect modification, where we would basically break people into groups and look and see whether we saw, for example, the benefits of private sanitation being beneficial at reducing infections in both people who washed their hands and people who didn't. Ultimately, the analysis was really messy. It was very difficult, and we did not find a lot of effect modification other than between sanitation and hand washing. So latent class cluster analysis is an approach that's used a lot in the broader population health literature, especially around environmental factors. Yes. Oh, okay, thank you. And, all right, and so what latent class analysis does is it looks at a bunch of conditions. For example, your floors, your sanitation access, your drinking water access, your hand washing behaviors. And it says, okay, who is like each other and who is not? And it tries to sort you into groups based upon who you look like, not just on one factor, but on the sort of broader composite of living conditions. So when we use latent class analysis on our socioeconomic and environmental conditions, we found that there were basically 5 distinct population groups that were similar to each other and dissimilar from the other groups. What this allows us to do is then take this sort of 5-group classification system into our model as a predictor of health outcomes. All right. We can look at this information, and we can also compare across clusters and within clusters how similar or dissimilar people are to each other, sort of an evaluation of how well latent class works. There is no perfect separation. Some people have shared conditions across clusters, but the clusters did have some distinct characteristics. And I'm going to show this to you in just a second. This is the different pathogens that we were looking for at 5 months and 9 months of age. So again, lots of different viruses, bacteria, and parasites. What you're seeing in this graph is the species on the y-axis, and on the x-axis, the percentage of positives. In blue is baseline when children were enrolled into the study. For that, at that point in time, it's what we detected in terms of a pathogen. In orange is when they matriculated out of the study. So what you can see from this is that there's a higher prevalence of infection at 9 months of age. When we look at pathogen detection counts per infant across clusters, we also saw lots of co-detection of pathogens in many different clusters, but there are some differences that emerged between them. And I'll show that to you in just a second. Oops, it's going the wrong. Okay. All right, so on the analysis end, when we took the cluster identity and analyzed whether or not cluster identity was related to self-reported diarrhea at 5 months, 8 months, and 9 months, what we found was that cluster 1 and cluster 2 and cluster 5 all had lower risk of diarrhea, self-reported diarrhea, at 5 months and 9 months compared to cluster 3. Cluster 3 had the highest prevalence of diarrhea. Now you'll also note that at 8 months, there's no significant association. So at 8 months, we did not find any relationship between cluster and self-reported diarrhea. I think the reason for this is that at 8 months, we were doing much more intensive observation of mothers preparing food in the home. So this is more than just a survey about whether you wash your hands or what you do. We were actually in the home for hours watching them, right? So I think this is highlighting some of the real challenges around using self-reported health information when people have already been triggered repeatedly as to how they're supposed to respond to some of these questions. Now, when we look at enteric pathogen data, right, this is a more objective tool. It's not influenced by courtesy bias of the people enrolled in our studies. What we found, again, is that there were some relationships between clusters and pathogen detection. Specifically, clusters 1, 2, and 3 were significantly less likely to have enteric pathogens isolated in their poop compared to cluster 4. Right, so cluster 4 had the highest pathogen diversity in their poop. All right, but at 9 months of age, that benefit is gone, right? So even if you're living in these households that had clean enough conditions to protect you from pathogen infection at 5 months, by 9 months, that benefit is gone. One of the reasons, or so what's kind of happening there is we're seeing between that 5-month and 9-month point of time, a really big increase in the population prevalence for a lot of these pathogens. And so I'm going to speak loudly and wander over here so that I can, I'll just use my hands. All right. So in orange here on the bottom, these are this is the pathogen prevalence for rotavirus, norovirus G1, Salmonella enterica, and Antwi-Agyei E. coli, but taking what was detected at 9 months and subtracting 5 months. So for these 4 organisms, the population prevalence dropped as children aged. But for the others, for all of these other ones in blue, we saw increases from anywhere from 0.1% between 5 and 9 months of age for norovirus G2, all the way up to 18, almost 19% for Campylobacter, Enteropathogen E. coli. It was a 25% in population prevalence increase. So there's a whole lot of exposures that are happening over this time frame, and the household conditions weren't necessarily protecting children at that point in time. So somewhere in here, let me go back. Somewhere in here I had a description of the household conditions. I might have deleted it accidentally. So what I'm going to do is I'm going to verbally describe what's different between these clusters. So cluster 1 and 2 and 5 are our wealthiest clusters, using like assets and income information. They had the most money to begin with. There were some differences between these clusters. So cluster 1 had the highest levels of private sanitation. They had very low levels of breastfeeding. They also had lots of finished flooring, right? So they were not living in homes with dirt floors or covered dirt floors. Cluster 2 was what we would call like middle class. Now cluster 2 also had pretty good floors, but it was dirt floors covered with vinyl, so not finished floors, but still the dirt is covered. They also had sort of high both of these clusters had very high hand washing behaviors, both for defecation and food preparation. Cluster 5 down here was unique for having high breastfeeding rates and they had lots of dirt floors. So here floors are different, right? So what stood out between these 3 clusters and cluster number, sorry, I'm on diarrhea. What stood out between these clusters and cluster number 4, here we see the sort of differences in pathogen diversity. Cluster 4 had everything wrong, right? Lots of dirt flooring, high levels of domestic animal ownership. They had decent food hygiene, hand washing behaviors, but very poor post-defecation hand washing behaviors. They had high rodent counts in the household. So there was really this composite of things, just all of the boxes as far as what you don't want to live with were sort of problematic in that household, or in the households that were assigned to this cluster. So going to my conclusions, latent cluster analysis is a very powerful approach for taking really complex exposure hygiene scenario issues and trying to parse them apart in ways that help identify intervenable points of action. Our data suggests that many joint interventions are likely needed. Your one-off food hygiene behavior promotion by itself is probably not going to be effective. But in combination with other things like flooring or animal hygiene control, you might be able to reduce pathogen diversity. Self-reported diarrhea is a problematic evaluation outcome. However, our objective pathogen diagnostic data did provide us this sort of very constructive way of comparing conditions and infections, as well as looking at time dynamics. And it also suggests that intervening very early in life is very important. If you wait till 9 months of age, a lot of the kids that you might be enrolling into the study already have high pathogen loads. So acknowledgements. Again, London School of Hygiene and Tropical Medicine, and African Population Health and Research Center, University of Iowa, and Great Lakes University all collaborated on the study. It was funded by DFID. The PI was Jane Muma at Gluck and Ollie Cumming at LSHTM. With that, thank you, and I apologize for any details I might have missed.
Thank you so much, Kerry, for that great presentation. I'll tell you the reason why we had Kerry and Amin no present when they're not showing up on the list. And we should give them a big clap for being able to stand in to make their presentation. So we're going to have some questions for Kerry, at least 1 or 2 questions to her. The last presenters that you see on the schedule were not able to make it here for visa issues. And Kerry and Amin no, we're really happy to share the exciting research in this session. So thank you so much to them. Let's have the question to Kerry. Yes. Can you please use the microphone so some people are online, so they won't be able to get the recording.
Just curious about the N for the LCA within each cluster and then overall.
The number, that's a great question. I don't remember the numbers right offhand, but cluster 5 was the smallest. So if you look at some of the data here, like for example, you'll note that it was trending towards being a beneficial set of hygiene conditions to live in for protection against pathogen infection. But this cluster had like 83 households, so there were probably power issues with really being able to detect meaningful differences.
Right.
The overall study was 888 infants. The largest group size was, I think, 190 households.
All right, a big clap to Kerry. Thank you so much for that. All right, I think that marks the end of this this session. Thank you so much. It's been a pleasure to have you talk about sanitation today. Bye.
We couldn't get our project manager here for her talk either.